Hi there. Good afternoon, everybody. This is the Health and Social Services Subcommittee. Welcome. We're happy to have you here today. We have first a quick voting session, and then what we'll do is we'll do our votes, and we'll gavel out a voting session, gavel into budget hearings, okay? So just a heads up on that. So we have two bills, members, first for the voting list. The first one is a departmental bill that we heard just this week. It's HB 214. This is the Human Services Maryland Assistive Technology Program Establishment. This was essentially codifying an existing program where within the Department of Disabilities. And we heard the bill earlier this week. There was no opposition, and there is no fiscal note. So I would like to ask for a motion on the bill.
So move the bill.
Second.
Okay, moved by Delegate Ruff, seconded by Vice Chair Jones. So we'll just do a quick voice vote. All those in favor, please signify by saying aye. Aye. Any opposed? Great. Thank you so much. That bill has passed unanimously. The second bill is HB 43. This is the Federally Qualified Health Centers Grant Program Acquisition of Land. This is by Delegate Jazz Lewis. We heard this bill 2 weeks ago, I believe, I'm sorry, you all know what time looks like these days. January 28th. And what this bill does is there's an existing grant program for FQHCs, and this bill would allow for an additional allowable use for the grant program that would allow FQHCs to apply if they're trying to use some of the funds to purchase land. There's no additional funds. It would just create an additional allowable use. There's no amendment, no opposition. Do I have a motion on the bill?
Move the bill.
Moved by the Vice Chair. Do I have a second? Second by Delegate McCaskill. All those in favor, please signify by saying aye.
Aye.
Aye. Any opposed? Great. The bill passes unanimously. Thank you so much. Okay, so we're going to gavel out. That concludes our vote session. Boom. Okay, now, welcome back. We are here for budget hearings today. It is February 13th, Health and Social Services Subcommittee on Appropriations. Today, we are hearing from 3 different budgets, and we will go in agenda order, I believe, correct? Okay. So the first one on our list is the MDH administration budget. And so we'll have Naomi Kimura, our DLS analyst, please come to the front or to the table and provide your analysis. Thank you so much. You can start when you're ready.
Good afternoon. My name is Naomi Kimura. I'm the budget analyst with Department of Legislative Services, presenting on the Maryland Department of Health Administration budget. This budget includes funding for the administration and operations functions of the Department of Health, and includes the budget for major IT projects, as well as the budget for the 12 inpatient state facilities. On the first page, you can see a summary of the budget from 2024 to fiscal 2026. Between fiscal 25 and 26, the budget grows by about $31 million to $847.1 million. On page 4 begins discussion of a couple of the performance metrics that the Department of Health submits data on an annual basis. The first is related to resident and staff safety at the inpatient facilities. The Department of Health has a goal of having no more than 1 assault per 1,000 patient days at each of the facilities. And in fiscal 2024, as you can see from Exhibit 1 on page 5, 8 of the 10 facilities failed to meet this goal. The rate of assaults increased most dramatically between fiscal 23 and fiscal 24 at the RICA Baltimore facility, which serves children and youth. Their assaults increased by 175%. The health department also submits data on patient injuries. The patient injury rate at certain state facilities is shown in Exhibit 2 on page 6. The second performance metric that I'll go over is related to admission times for court-ordered patients. when found incompetent to stand trial or not criminally responsible, some individuals are court-ordered to seek treatment at Department of Health facilities. And for most of these people, the Department of Health is required to place them in an appropriate facility within 10 days. Exhibit 3 on page 7 shows that in fiscal 22 and fiscal 23, the department did not admit any of the required patients within the 10 business days, and it's been decreasing since fiscal 2020. The Department of Health has said that a big challenge preventing them from placing people is available bed capacity. So at the 5 adult psychiatric hospital facilities that the health department operates, they are currently operating at a capacity of 95% or more. And then there's also challenges with hospital discharge, where to put people once they no longer need the inpatient care that they're receiving at the facilities, but still need some sort of support. So on page 8, there's a brief description of some of the programs and initiatives that the health department operates to try and support people's transition out of these facilities and into other forms of care. Related to both of these metrics is more of a data issue with some of the data we receive from the Department of Budget and Management. DLS has asked MDH and the Department of Budget and Management to comment on the process they use to populate and submit MFR data and how they will ensure that there's accurate data reporting in the future just to support analysis. The rest of this page, page 9, includes some of the budgetary actions impacting the fiscal 25 budget. I'll point out a cost containment measure that was authorized by the Board of Public Works in July of 2024, reducing the fiscal 25 appropriation due to, by $2.5 million due to the delay of new bed units at the Thomas B. Finan Hospital Center. There's also a proposed negative deficiency that would withdraw $6.8 million for staffing those units at Finan. On page 10, there's a list of the proposed deficiencies for fiscal 2025 included in the fiscal 26 allowance. These result in a net $13.3 million addition to the general fund appropriation in fiscal 25, the largest of which is $9.8 million, which would support temporary HVAC systems at Perkins. The HVAC systems at Clifton T. Perkins failed, and so in the interim before building a permanent solution, the department had to have an emergency procurement to install temporary equipment. Page 11 breaks out the fiscal 26 budget under the Department of Health Administration. The majority of the budget, as you can see, is dedicated to the many personnel that work at the state inpatient facilities. On page 12, there's another pie chart that breaks out the spending, not including the personnel costs. So majority is going toward operations. There's also nearly 30% of the budget dedicated to the opioid response grants, which includes opioid restitution fund grants, as well as others. On page 13 and page 14, there's a summary of the major changes in the budget between fiscal 25 and fiscal 26. So again, the entire budget grows by about $30.9 million, and that change is really driven by increased costs for personnel, as well as provider reimbursements in line with the Family Act that were budgeted in the administration budget, but will be distributed to BHA, DDA, and Medicaid to support provider reimbursements in those budgets. On page 15, there's a summary of the personnel data in this unit of the health department. There's a vacancy rate of 14.69% as of December 31st, 2024. Most of those vacancies are at the state hospital facilities. So of the 656.6 vacant positions, 91% of them are in the state facilities. On page 16 begins discussion of the first issue included in this analysis, which has to do with high vacancy rates at the facilities and limited bed capacity, which have implications for state staff and patient safety, as well as serving patients' needs. On page 17, Exhibit 7 shows the vacancies and the vacancy rates at the 5 adult psychiatric facilities and the 2 RICA facilities, which serve children and youth. So the highest vacancy rates are at Thomas B. Finan and at Perkins. Exhibit 8 on page 18 shows the number of vacancies at Clifton T. Perkins between fiscal 2011 and 2025, as well as the vacancy rate. And so you can see that it has been increasing since fiscal 2020, reaching a peak of about 28% in fiscal 2025, again, as of October 31st, 2024. The rest of this discussion describes some actions that the Department of Health has taken to address vacancy rate, as well as some other issues at Perkins. DLS is recommending adopting committee narrative that would require the health department to submit a report with information on bed capacity and the patient length of stay at the Perkins facility. The second issue that I'll discuss briefly is related to the Center for Firearm Violence Prevention and Intervention, which was established by 2024 legislation in the Prevention and Health Promotion Administration, but as of this year has moved to the Department of Health Administration budget. Exhibit 9 on page 20 just shows firearm mortality rate among high-income countries as well as Maryland. And so both the United States and Maryland, which have similar mortality rates by firearm, are well above many other, most other high-income countries included in this data set. On page 21, summarizes the progress that's been made to date to establish the center, including hiring an executive director, creating an inventory of existing programs dedicated to violence prevention, as well as stakeholder engagement and community input. And by the end of March 2025, MDH reports that it plans to release a request for proposals to support violence prevention programs across the state. They've also been developing a firearm violence dashboard with data on firearm-related injuries. The rest of this discussion on pages 22 and 23 just discuss other violence prevention efforts that are taking place across the state, both in local jurisdictions and in private institutions, including the University of Maryland Medical Center and Johns Hopkins. Lastly, on page 24, there's a very brief issue summarizing findings from a recent fiscal compliance and audit done by the Office of Legislative Audits. DLS has asked MDH to comment on the steps that it takes to the steps it plans to take to address the findings that were included in that audit. And with that, I'll close just by summarizing DLS's recommendations, which was just to adopt the committee narrative, requesting a report on bed capacity and patient length of stay at Perkins. That concludes my presentation.
Thank you so much. We really appreciate your thoughtful analysis. Do any members of the subcommittee have questions? Seeing none, thank you. Okay, we'll bring up our MDH witnesses. Hello, Madam Secretary, welcome back. We are pleased to see you and your team, and you can introduce whoever you wish is joining you, and you can go when you're ready. Thank you.
Thank you, Chair Shetty, members of the committee. I'm here today with Emily Brandenburg, our Chief Financial Officer, and I'd like to thank Naomi for her detailed analysis. But before I get into my personal comments, Chair Shetty, I just wanted to personally thank you for all your support in my 2 years in the role. We did a lot of great things, and I appreciated this committee's support every time we sat before you, so thank you. So the MDH administration analysis covers a lot of ground, so I'd like to take a moment to provide a few comments on 2 key areas highlighted in the analysis. The first is centered around our 11 state-run facilities, namely our 5 adult psychiatric hospitals. We have 5 adult psychiatric hospitals, 2 nursing homes, 2 regional institutes for children and adolescents, which are for children with severe emotional disturbance, and then 2 nursing homes. And then the second is focused on the Center for Firearm Violence Prevention and Intervention. First and foremost, the analysis highlights a number of complexities related to our state psychiatric facilities. As noted, over the past 4 fiscal years, there's been a significant increase in the number of court-ordered patients to MDH facilities. And we are at a juncture where the number of court-order placements for our facilities meets our total bed capacity, resulting in a growing hospital wait list, which you may have heard about. In FY24, there were 995 court-order placements to our facilities, and we only have 1,056 beds across all 5 adult psychiatric facilities. These facilities, as was already noted, are operating at almost full capacity, 95+%. It is important to note that the number of court-order placements is a mere fraction of the number of evaluations we are required to conduct, and last year that was over 3,500. So depending on that number, and that number continues to grow, as you can see, it far exceeds our capacity. I'd like to discuss the progress underway at Clifton T. Perkins. DLS highlighted a number of initiatives that are underway at the facility across 4 areas: leadership, staffing, environmental issues, and the availability of community placements. In the domain of leadership, we've made a number of key hires, and starting next week, next Wednesday, which I'm incredibly excited for, Dr. Aaliyah Jones will join the facility as its new CEO. Some of you may remember that she was the Deputy Secretary for the Behavioral Health Administration under Governor Hogan, but she's a seasoned leader with a strong vision for the facility. We've also hired a new Chief Financial Officer and are actively recruiting for a new Chief Operating Officer. So the whole leadership structure is being replaced or has been replaced. As it relates to staffing, myself and other senior leaders of the department have spent significant time at the facility meeting with staff and executing new opportunities to address recruitment and retention as well as staff training. We've also taken a hard look at policies and process related to incident reporting, including those that relate to resident and staff safety. In September, we implemented a new incident reporting policy across MDH facilities. And just for a little more context, we're using a triage system almost like an emergency room, because all incidents were reported equally, and some were the hot water's not working to an assault, and we were really trying to address the egregiousness of those things so we could work with the facilities to understand what was happening and mitigate those moving forward. But this new procedure allows for greater transparency and faster identification of incidents that result in staff or patient harm, and again, with the goal of mitigating that in the future. Finally, the governor's budget makes investments in Perkins to address environmental concerns. In FY25, nearly $10 million is included as a deficiency to supplement the appropriation for an emergency contract to temporarily replace the HVAC system at Perkins. There are other highlights in there, but you'll hear more about those in the Behavioral Health Administration's budget hearing. I also wanted to highlight some of the progress underway with the new Center for Firearm Prevention and Intervention. Jen Policonis started as the executive director for the center in January. She's a national thought leader in this space with previous experience working with both grassroots organization and academic research partners. The center will soon launch a firearm data dashboard, similar to the opioid data dashboard, where you'll be able to sort by zip codes, by race, ethnicity, by firearm type, homicide, suicide. The data can be used at the local level to drive decisions to inform violence intervention programs. We anticipate funding opportunities to be made public in the coming weeks, so we hope by early March we will have our own RFP to start funding some of the initiatives that we testified to last year. And lastly, we are expanding the data capabilities at the center, and recruitment is underway for our epidemiologists/data analysts to review this data. So with that, I'll jump into our responses. Concerning the need to ensure accurate MFR reporting in the future, MDH recognizes the need for greater oversight of its performance data. We are realigning staff resources to the department's data office under the Chief Data Officer, which will be charged with secondary review of MFR data prior to submission. This will address any data anomalies at the program level before performance data is shared with DBM. Regarding the request for a report on bed capacity and length of stay at Perkins, we concur with DLS recommendations for the adoption of committee narrative. And then last, DLS prompts us to comment on steps to address fiscal 2024 closeout findings. I'm going to go over them, but you have the detailed analysis, including the visual that we worked on with our partners, just to give you an idea of the clearing accounts. For finding one, this is a similar finding that was noted in our prior 2 closeout audits. We are working with our partners at Deloitte to reconcile the Schedule G. Currently, the team is working on DDA and the Medicaid clearing accounts. We anticipate this finding to be resolved by the close of FY25. Of the 10 positive samples that OLA selected, MDH was able to support the revenue accrual for both Medicaid samples. The additional samples were either DDA or the clearing accounts, which, as previously mentioned, are our current focus. You have the graphic that talks about the Medicaid clearing account allocation process and why it is critical to analyze all balances when reporting any shortfalls. There is not a shortfall in Medicaid reimbursements as of June 30th, 2024, but rather a $476 million surplus that needs to be allocated out of the clearing account. So it doesn't mean it's just free money, it just means it has to be moved to the appropriate accounts. Deloitte performed 20 Medicaid and DDA reconciliations between the Payment Management System, Overall Clearing Account, MMIS, and the Financial Management Information System, or FEMIS, to confirm revenue received has been correctly allocated within FEMIS. These reconciliations required reviewing 49 million transactions and covered 28 fiscal quarters. Deloitte created 18 business process documents and 3 automated workbooks, which have aided with standardizing current business practices. Now, this is really important because one of the original OLA findings was that there was one person that a lot of this work hinged on. That person left, and then the work stopped. So now there are standard operating procedures in place to prevent a single point of failure moving forward. We are to continue to focus on confirming the accuracy of federal reimbursement claims through the MMIS and FEMIS to CMS 64 reconciliation, clearing allocation variance adjustments through weekly and quarterly drawdown and clearing account reconciliations, as well as analyzing the Schedule G surplus accounts. MDH is working to ensure that all year-end revenue transactions are properly supported. And then concerning finding 2, MDH reported unprovided for general fund payables and other potential general fund liabilities totaling approximately $273.6 million as of June 30th, 2024. Funding is provided in the fiscal year 2026 budget to address the disallowed DDA claims, and fiscal year 2025 deficiency funding is included in the governor's allowance to support unprovided for Medicaid payments. OLA suggests a potential liability for unspent MFP funds that must be spent by September 30th, 2025. However, the MFP demonstration grant was renewed until September 30th, 2027 by the Consolidated Appropriations Act 2023, passed in December 2022. MDH anticipates spending the enhanced funding before the extended deadline. Finally, we note that finding 7 from the fiscal year 2023 closeout audit, MDH did not properly report unrecoverable federal funds totaling up to $8.8 million to GAD, which has been resolved. So I know that sounded like a word salad over the last few pages, but you have the details in front of you, and myself and our Chief Financial Officer are happy to answer any questions, and that concludes our formal response. Thank you.
Thank you, Madam Secretary, and thank you for being with us today and for all of your incredible work over the last couple of years. I always sort of half joke that we're very, very fortunate in this subcommittee that we have the best cabinet secretaries and the best agencies, but it's true, and we have really found it to be such a privilege to work closely with you and your incredible team on the many, many challenges that you've had to face and your agency has faced. You've always handled it with beautiful grace, and at the same time getting some really, really big things done beyond just putting out fires. So we have a lot to learn from you, and I certainly have learned a lot over the last couple of years during our working relationship. So thank you. Do any members of the subcommittee have any questions for our MDH team? I know I have one. So I'd like just to kind of take a peek at page 4 of the DLS analysis. So this is related to staff and resident safety. at MDH facilities. So patient on staff assaults have increased quite a bit at half of the facilities. I recognize these are extremely challenging jobs with very, very significant challenges. So I want to see if you could please comment a little bit further on the steps that have been taken to help protect our workers and at the same time also ensure that patient safety is guarded.
So some of it is the increases due to some of the change in the structure and the way that we're reporting. I will say the facilities were put into a healthcare system under the prior administration, and it made sense for things like procurement and sharing of resources, but what was lost was some of the clinical oversight, including some of the reporting that was happening. And so because they all came in and they were equal to each other, we really changed the definitions for what's a critical incident, level 1, level 2, et cetera. So there has been an increase in the numbers, but some of that is reporting. Now, what is real is it is due to the staffing shortages in some of the facilities, both on the clinical side and on the security side. So we've been working, we have a new HR director. She's put plans in place, especially for Spring Grove and for Perkins, where some of these resources were short, as well as at the regional institutes for children and adolescents. So there's been additional resources at the facilities. There's also, in some cases, we've done ASRs to increase the amount we pay our clinicians. So for instance, social workers at the RICAs, compared to other areas where they could work, their salaries were not high enough. And so keeping and retaining social workers were incredibly hard. I will also just say, overall, the acuity of the patients that we're receiving is way higher than we've ever seen before, not just in the children, but on the adults, and not just the acuity of their mental health, but also the criminality of which they're being charged and being moved to our facility. I try and remind everyone, we don't run a prison. They are hospitals, and so we don't have the resources that a correctional facility have, but there is a fair amount of training that's happening with our security staff and our clinicians. Is it great or adequate? I would say no, but we are actively working on assessing our training staff, because if we don't have good trainers, then the training the individuals get is inadequate to do what they need to do. So we're assessing the training staff as well as the actual training materials that they're getting. So it's still a work in progress.
Thank you so much. Delegate McCaskill for a question.
Thank you, Madam Chair. Thank you all for being here. So if you all know me, I always have a good old personnel question to ask. So I'm referring to the data that's on page 15. So we know that there's a direct correlation between the high vacancy rate and the limited bed capacity and for safety. And so my question is that it mentions most of these 596 in total are with state-owned facilities. So I believe before, and I want to thank you for providing more information in the overview of that, the budget hearing, but what is being done to recruit and retain for these positions specifically?
For the ones for the facility?
Yeah.
So a lot of the vacancies, as I said, are at Perkins and Spring Grove.
Right.
And so we have very detailed plans, HR plans, in partnership with HR and the leadership of the facilities for those two facilities in particular, and depends on the role. So the approach to nursing staff is a little bit different than the approach to security staff, but we're doing health fairs, we're doing on-site job fairs, because that's one of the other things is people may not be familiar with what it's like to work in a forensic psychiatric facility, and they may have worked in a psych unit in a hospital, but it's still very different. So we're doing on-site job fairs so they can see the facility and understand the role in the facility that they would be practicing. We're participating in other job fairs. We are way more active than we've ever been around recruitment in general, where they used to just go up on the MDH website. But we are actively working all the different roles through all the different channels. And for nursing, for example, even with the schools of nursing as new graduates come out. So it's a multi-pronged approach, and we can certainly share that with you.
Perfect, because you went right into what I was going to ask as far as the approach with these positions versus the other positions in the department.
The approach is different because those positions are clinical and they're patient-facing. So the approach is very different. We have to make sure the way a hospital or any other clinical setting that they're licensed, up to date on all their requirements related to their licensing for a clinician. There is training that the security attendants need. So again, we can provide that outreach we've been doing for both those facilities.
Perfect, thank you.
Sure.
Thank you, Madam Chair.
Thank you, Delegate. Thank you, Madam Secretary. Delegate Acevero.
Thank you, Madam Chair. I'm not sure if this will be the last time that I or you come before this subcommittee, but just wanted to express my gratitude for all of the work that you have done, not just in the role as Secretary of Health, but prior to and all of your professional experience that you've brought to bear to serve Marylanders in our state. I know this is a job, the work that we do, it's really thankless work. And oftentimes, folks don't recognize just some of the effort and the hard work that is done, including behind the scenes, to make sure that things operate the way that they do. But I will say this, Latino is certainly proud that, of all of your accomplishments, but your willingness to step up and to serve and to do so in an agency and a department that is certainly not easy to lead. And so I'm not sure if I will see you before you demit office, but I wanted to just express openly my gratitude, my appreciation, certainly that of my constituents for all of the work that you've done, Dr. Herrera. You and Secretary Lopez have always brought pride to a lot of our community, the Latino community in particular, for your leadership. And again, just thank you and wish you all the best. No doubt you will continue to be involved and using your expertise in healthcare to ensure that we're improving outcomes and statistics. Again, just thank you, and I look forward to continuing to work with you in whatever capacity. But really, really appreciate all the work that you've done. I didn't have a question, but I certainly wanted to express that. So thank you.
Thank you. Thank you very much.
That was beautiful. Second from all of us. So I see no further comments or, whoops, excuse me. I do see a question, I guess. Okay, forgive me. One more question, Delegate Heimbaugh. Of course.
Of course, ditto. It's an incredibly difficult job. I wouldn't want to try it. I'm just curious on what's the biggest impediment to hiring people? Is it wages or just the skill base that's not out there? Or what are the biggest impediments?
So for the clinicians, there's a workforce shortage, full stop, national. It's not specific to Maryland, but we are competing against hospitals. We are competing against doctors' offices. We are competing against everyone else for the same resource. And then throw in the forensic piece of it, and it complicates things. There's not as many nurses that are trained psychiatric nursing and or interested in the patient population. So it just makes it a little harder. On the social work side, they can get paid more money in other areas. Generally, the people that come to our facilities, especially our Rikers, are absolutely committed to the patient population, so they choose us. But it takes a little while to find those people that choose us. In other cases, it's definitely the salary ranges, but DBM has worked with us through ASRs to improve the salaries to attract qualified clinicians. So it's a multitude of reasons.
So have you attempted or been, maybe it's not practical, but I'm just curious, have you attempted or been able to do any creative type things? Like, is there a way you can, I don't want to call it OJT, but is there a way you can identify people that you think have the prerequisite skills to be successful in these occupations to get them before they're certified or whatever? I mean, as part of the recruitment process, are you able to do anything like that?
So we do, especially with like the schools of nursing before they even graduate. So we do that. And like I said, I'm happy to share the plan that we've put together of the different ways that we're attacking this problem to fill the vacancies that we have in our facilities.
Yeah. Thank you. Thank you, Madam Chair.
Thank you, Delegate. Thank you, Madam Secretary. That seems to conclude our questions and comments, so thank you again for joining us. We do have one witness who has signed up to testify favorable with amendment, Jenny Reese with AFSCME Local 539. Great. When you get to the table, you can begin when you're ready. You have 2 minutes to provide your testimony, and then we'll do questions after from the subcommittee. Thank you.
Good afternoon. My name is Jenny Reese. I'm the proud president of AFSCME Local 539 and the Maryland Department of Health Unit Vice President of AFSCME Council 3. This past year, I've had the opportunity to visit several of our MDH facilities. To say this experience has been eye-opening would be an understatement. From Eastern Shore to Western Maryland, staffing is a major concern, and the lack of resources for our clients alarming. In our state maximum psychiatric hospital, Clifton T. Perkins, patients participate in less than an hour and a half of therapeutic activities a day. We do not have enough social workers, rehab, and other supportive services to provide them with the resources they need throughout their hospitalization to assist them in returning to the community. Due to this shortage, we continue to see assaults, both patient to patient and patient to staff. Without being engaged in therapy, there is little for patients to do other than think about and exchange plans to execute a contraband exchange and get into altercations with one another. Security and nursing are short as well. There isn't enough security attendants for every post. Units that should have at least 4 staff for over 25 patients have been operating with only 2. Employees have not been relieved for their meal break, resulting in one recently passing out because their blood sugar was so low and 911 had to be called. It isn't only at Perkins that we are short-staffed. Our CI hospitals are suffering as well. This is unacceptable and a complete disregard to safety for both our patients and our staff. Our health departments are losing employees due not only to safety concerns, but unrealistic caseloads. The current budget proposes a $6.8 million cut that was initially for Fine and Center cottages to make beds available to patients to prevent MDH from continuous scrutiny for the wait list of the list of incarcerated individuals awaiting admission for psychiatric evaluation and treatment. We are the Maryland Department of Health. We need to do better. Our employees and Marylanders deserve better. I went into this profession to provide quality patient care for those suffering from mental illness. Without staff and adequate resources, we are simply unable to strive to our full potential. Please pursue alternatives to cuts to state services. Thank you.
Thank you so much for your advocacy and for joining us today. Do any members of the subcommittee have questions? I see Delegate McCaskill.
Thanks again, Madam Chair. Thank you for being here. It's always good to have a good balance between the agency and the employees. And so my question for you is quite simple, and maybe not. What do you think would help with the staffing issues?
Thank you, Delegate McCaskill. That's a great question. AFSCME, we would like to work collectively with the agency to establish staffing plans specific to our facilities and their individual needs.
Thank you. Perfect. Have you already had a discussion yet with that possibility, or is that in the works?
Yes, Delegate, we have.
Okay, perfect. Looking forward and hope successful conversation. Thank you. Thank you, Madam Chair.
Thank you, Delegate. Thank you again for joining us today. Seeing no further questions, I appreciate it. Thank you for joining us. That concludes our consideration of the MDH administration budget. So we will now go to the MDH Office of Healthcare Quality, and we'll invite our DLS analysts back to the table to provide their presentation. Thank you. You can join when you're ready, or you can begin when you're ready. Thank you.
Thank you, Madam Chair and members of the committee. My name is Victoria Martinez, and I'll be presenting the Office of Healthcare Quality Analysis. The office licenses and certifies several types of healthcare programs and facilities for compliance with state and federal health safety and quality of care standards. As you can see on the cover page, the fiscal 2026 allowance increases by $2.2 million or 5.4% for a total of $41.9 million. On the next page in the discussion of fiscal 2025, I'll just note that section 21 of the fiscal 2025 budget bill added $103,000 in general funds and 1 regular position for an additional health facility surveyor nurse in the long-term care unit, and DLS has asked the agency to comment on whether the added position has been filled. Moving on to the agency spending, Exhibit 1 on page 3 shows the agency spending. About 83% supports personnel, but there's also a $4.4 million contract for nursing home subcontractors and grants. Exhibit 2 on the next page shows the personnel spending by monitoring unit, with the largest portions being in the long-term care unit and the developmental disabilities unit. The proposed budget it is discussed on page 5 in Exhibit 3. This shows a breakdown of the $2.2 million increase. The largest increases are for personnel expenses, with various smaller changes in expenses relating to the nurse surveyor positions and administrative changes. In terms of personnel that's discussed on the next page, there is no change in regular or contractual positions in fiscal 2026. Exhibit 4 shows the vacant positions by program and position type. This exhibit is on page 7. The agency has made significant improvements in filling vacancies, with a current vacancy rate of 5% compared to 17% last year. Moving on to the discussion of the key observations. The first key observation on page 8 discusses the office's mandated survey activities and progress in meeting their goal of surveying all providers annually. Exhibit 5 on page 9 shows the annual survey rates in the developmental disabilities unit, and Exhibit 6 on the next page shows the same thing but for the assisted living unit. From fiscal 2023 to 2024, both units showed significant improvements in meeting their annual survey mandate. Exhibit 7 on page 11 shows the long-term care unit survey activities, showing some improvement in 2024, but since only 21% of facilities received an annual survey, DLS has asked the agency to provide the average and maximum time elapsed between surveys in fiscal 2024 and 2025. The next key observation that begins on page 12 discusses improvements in resolving the long-term care program complaint investigations backlog. Exhibit 8 shows the number of complaint investigations received and completed. The percentage of completed investigations has shown significant improvement, almost doubling from fiscal 2022 to 2024. The agency completes investigations based on CMS guidelines for prioritizing complaints based on the risk to a participant's health and safety. These priority levels are summarized in Exhibit 9 on page 13. And then Exhibit 10 on page 14 shows the investigations completed by priority. So only 1% of cases were categorized as the highest priority of immediate jeopardy, while 91% were either low or medium priority. Page 15 discusses the backlog of cases in the long-term care unit, which is estimated to be resolved in 2 years, with 2 contracts awarded for nurse surveyors to conduct overdue complaint surveys. The contracts total $5.6 million and are primarily funded with $3.9 million in general funds and $1.5 million in special funds. Since the agency's fiscal 2025 and 2026 budgets include less than $600,000 in special funds, DLS has asked that the agency clarify the source of the special funds. The contracts provide 5 to 13 nurse surveyors per week, depending on availability, for a total contract of $5.6 million. Considering that the total cost of salaries for 72 state employee nurse surveyor positions is $6.8 million, the agency should comment on the cost effectiveness of the subcontractors compared to full-time positions. The last key observation provides an update on the final federal rule on staffing requirements in nursing homes. Exhibit 11 on page 17 summarizes the new staffing requirements and the timeline that facilities have for implementation. The agency will then monitor facilities for compliance during annual surveys. And I'll end the presentation with DLS's recommendation, which is to concur with the governor's allowance.
Thank you so much for your thoughtful presentation and these meeting materials. They're very thorough as always. Do any members of the subcommittee have questions for DLS? Okay, seeing none, thank you. We'll now, sorry, let me grab this. We'll now welcome our department witnesses, Dr. Kalyana Raman, and anyone you wish to bring to the table. Please begin when you are ready. Thank you. Welcome back.
Thank you. Good afternoon. Good to see you all again. Thank you, Chair Shetty and subcommittee members for having us today. For the record, I'm Dr. Nilesh Kalyana-Raman, the Deputy Secretary for Public Health at the Maryland Department of Health. And I want to thank Victoria for her work with us. I'm actually going to turn it over to Tia Witherspoon, who is the Executive Director of the Office of Healthcare Quality, who is joined us just this fall. Yes. So we're very happy to have her. I will turn it over to her.
Thank you. So good afternoon, Chair Shetty. Good to see you in person. And Budget Subcommittee members. It's my pleasure to be here today, and I'd like to also thank Victoria for her detailed analysis and extend my gratitude to the dedicated staff at OHCQ, whose hard work is vital in protecting the health and safety of Marylanders. As the healthcare industry continues to expand rapidly, OHCQ remains committed to adapting and ensuring that Marylanders can trust their healthcare systems. OHCQ currently regulates over 22,000 providers and 47 different industries, and that's a 5.5% growth from 2023 to 2024. Some of OHCQ's notable highlights this past year include accelerating our survey activity in the long-term care unit. And fiscal year 2025, the annual full survey completion rate increased to 160%, and in the first six to 7 months of the fiscal year, we've already completed 77 annual surveys. In addition, we've increased the rate of completed investigations for complaints by 72%, and we've cleared over 5,000 complaints in the first 7 months of fiscal year 2025. We've also increased our recruitment, and we filled 12 long-term care nurse surveyor positions, and this will allow us to reduce the backlog even faster and eliminate the need for the contract surveyors. The committee has received our analysis, but I just wanted to highlight a few points for you. That the average interval time between surveys has decreased by 21% in fiscal year 2025. And what that means for us is that allows us to get into these facilities and clear out the backlog even faster. Also, the use of the nurse subcontractors has been critical because it allows us to immediately go into these facilities on day one and decrease that backlog. Since 2019, every nurse hired by OHCQ has not had the necessary certification to start survey activities immediately and has had to go through CMS's 12-month training to get certified. As the 12 surveys added in fiscal year 2025 go through training and become certified, again, this will help us get through the backlog quicker and eliminate the need for those contract surveyors. So I'll stop here and see if you have any further questions for us.
Thank you so much for your testimony. Really appreciate it. Do any members of the subcommittee have questions? I will start. I have a question related to the Object Fund Appendix, Appendix 1, if you wouldn't mind turning to that, please. Could you speak to the reason for the 97.2% increase in travel costs for FY26? Towards kind of like the bottom third.
Sure. That is, so we've been increasing our, as Ms. Witherspoon noted, we've been increasing our survey activity, so that is actually the travel cost of our surveyors
Wow,
that's going
okay.
up. So
Okay.
a good thing from our
A
perspective.
good thing, yeah. Okay, got it. Thank you, I appreciate it. Other members have questions? Delegate McCaskill, I see you first.
Why, thank you, Madam Chair. Good afternoon to you. I have a question right on page 1 of the DLS report. So I'd like to discuss that federal funding a little bit further. Okay, perfect. So you received approximately $10 million in each of the prior 2 years federal sources to inspect facilities with Medicare and Medicaid-funded patients. So could you speak more on the breakdown about where the funding went?
So we can give you more detailed, I can give you a general overview, and then
Okay,
we can get you
perfect.
some more details on that.
Sure.
Probably over half of that is going to our LTC, to our long-term care unit. So the way that surveys are funded is that the federal government does provide funding for that, but it is not the full amount of funding required to carry out all the surveys. The last time there was an increase in funding was in 2015, I believe. And so that's a well-known issue across the country. The remainder of the funds go to a variety of programs, and like I said, we can give you the full breakdown.
Perfect. Specifically want to refer to, when you do the breakdown, to how much is going to nursing home inspections.
Yes, we'll certainly do that.
Okay, and I've heard that it might be about 3.2 million. Is that accurate, around about?
I would say it's probably a little bit more than that, actually.
Okay.
But it varies by year based on what we draw down. But we'll, like I said, we'll get you that.
Perfect, I appreciate it. Thank you, Madam Chair.
Thank you, Delegate. Thank you, team. Delegate Ruff.
Thank you, Madam Chair, and thank you to the panel. I wanted to talk about the long-term care unit survey activity. Could you give us an understanding of what all goes into the survey, kind of the mechanisms, how is it provided, and what exactly do you all obtain from the survey?
So thank you for that question. The survey process is one that can be quite detailed. So we do quite a few different surveys. We do a complaint survey. That is if somebody has a complaint about a facility and they want us to go and investigate. That is usually a shorter survey. We do a full annual survey. That's the one that I referenced earlier, the 77 that we completed. That's when we're going in and looking at everything in the facility, from life safety code issues to the food, dietary, nursing services. We are looking at everything, and that is done annually. And that takes a little bit longer. That could have our team in there for probably about maybe a week or so doing that survey. It's quite comprehensive.
So it's essentially an investigation of the facility, the annual survey.
The annual, just making sure that they are in compliance with state and federal regulations is what it is.
Are there regulations that require these surveys to be done?
Yes, both on the state and federal side.
And that's incumbent on the department, correct?
Yes, that's correct.
So I'm looking at page 11, Exhibit 7, and I'm trying to figure out what's driving the low number of these comprehensive surveys being conducted over the past couple of years. It seems like there is funding for the inspection, so we're trying to figure out how is that funding being used if these surveys aren't being done.
Right, thanks for that question. So over the past couple of years, we've seen that we've had to do increased recruitment efforts to get these surveys done. We have since this year, we have since, and last year, we have since recruited and have been getting more surveyors and to do these annual surveys. There has also been an issue with COVID when we were under a federal mandate to stop those annual surveys, and what we had to do was do infection control surveys instead. So you'll see that in the data from 2021 and 2022 where it was low. We were not doing annual inspections because of a federal mandate. And then you'll see that the data starts to pick back up between 2023 and 2024, where we are going back in those facilities and picking up and starting to do inspections. But we're also coming out of that backlog as well in those years.
I'll just add one more thing, is that we did have in addition to the just high turnover that we had during COVID in terms of our surveyors, we also had a cybersecurity incident that stopped our work almost completely for about 5 to 6 months. So on top of the COVID and on top of the personnel loss.
So is there a plan for this fiscal year or going into the next fiscal year to ensure that we can, 5X these results? Because it looks like there are only 20% of long-term care facilities in the state have had this mandatory investigation.
Yeah, there is definitely a plan. Thank you for that question. There is actually a 3-part strategy to our plan. And the first one, as we talked about, is securing that base of increasing our state surveyors, which we have done. The also piece to that is making sure that we have those contractors in place, because as I mentioned, those contractors on day one, they come in and they are able to get into these facilities. They come in trained and ready to go. And then what we're doing also on the back end is we have increased our training at OHCQ. We are making sure that our surveyors are efficient. We are looking at ways that we can ensure that when they're coming back to write those reports, that they're doing them well, they're doing them quickly, and we're able to mobilize that team again and get them back out the door.
So you guys would believe that with this three-pronged approach, that the long-term care facilities across the state are going to receive the review that they need to ensure that vulnerable adult abuse is not occurring, that, like we spoke about yesterday, that there's no abuse of controlled dangerous substances going on, and that there are significant and adequate controls going on, because I think these are the concerns that we have about the lack of investigation that's happening. So I hope that we can see those results once we come back here next year.
We are confident that you will see those results, and then just to put a fine point on it, Senator, that just because
you gave me an upgrade.
I'm giving you. I'm sorry. But just
better than the other way, right?
Just to get just a fine point on that is that even though we may not have gone into the facility for the annual review, it doesn't mean that our teams aren't in the facilities. If we get complaints that there is immediate jeopardy, immediate harm to residents, we will be in those facilities within 2 business days. So we may not be doing the full annual review where we're looking at everything, but if there is a complaint, if we hear that something is going on that's egregious, our teams will be in those buildings within 2 days to investigate that issue.
Thank you, Madam Chair.
Thank you, Delegate. Thank you, team. I don't see further questions from our subcommittee, so thank you for joining us. That concludes the budget hearing for the Maryland Department of Health, Office of Healthcare Quality. We will now move on to our 3rd and final budget of the day, Maryland Health Professional Boards and Commissions, and we'll have Victoria Martinez join us at the table again for the DLS analysis. Thank you. You can begin when you're ready.
Thank you, Madam Chair and members of the committee. My name is Victoria Martinez, and I'll be presenting the analysis for the Health Professional Boards and Commissions. The Health Professional Boards and Commissions work to certify and license health professionals and to resolve customer complaints. As you can see on the cover page, the fiscal 2026 allowance increases by 6.2 million, or 13.4%, for a total of 53 million. The majority of the budget is funded through special funds that's generated through licensing fees. Exhibit 1 on page 3 shows a breakdown of the agency spending for fiscal 2026, most of which supports employees and contract expenditures. Exhibit 2 on page 4 shows the breakdown of the 6.2 million increase. There is an increase of 6 million budgeted in miscellaneous personnel adjustments. The MDH clarified that this was included in error and that there is no planned use of that appropriation. So DLS recommends reducing this allowance to correct this technical error. Aside from that, the biggest changes relate to the sunset of the legislation that transferred Board of Nursing infrastructure operations to the MDH Office of the Secretary. These functions were budgeted as general funds in MDH and reimbursable funds in the Board of Nursing. Since infrastructure operations return back to the board in fiscal 2026, several changes reflected the decrease in reimbursable funds and increase in special funds to cover these costs going forward. Moving on to the discussion on page 6 of the Budget Reconciliation and Financing Act, the BRFA includes 9 board fund balance transfers to replace general fund spending under the Behavioral Health Administration. Exhibit 3 on page 7 shows the special fund balance transfers of each of the boards and the balance as a percentage of their allowance. After the BRFA transfers, some of the boards are left with a much higher balance as a percentage of their allowance. And because of this, DLS recommends amending the BRFA provision to authorize additional transfers from the boards that had a balance as a percentage of their allowance higher than 50%. The rows that are highlighted in green in the exhibit reflect the DLS recommended modifications to the BRFA. DLS also recommends eliminating the proposed transfer for the Board of Optometry so that they aren't left with a negative fund balance after the proposed BRFA transfer. Moving on to the discussion of personnel on page 8, there's an increase of 3 regular positions, which are all contractual conversions in the Board of Nursing. Exhibit 4 on page 9 shows the vacant positions by board. The vacancy rate is 12%, which is about the same as last year, but the Board of Nursing had made significant improvements in decreasing the vacancy rate within their board. Going on to the first key observation on page 10, this key observation discusses the board's status in meeting their investigation goals relating to issuing new and renewal licenses and completing complaint investigations. Exhibit 5 on page 11 shows the number of boards that have missed each of these MFR goals, and Exhibit 6 on the next page shows the boards that missed these goals and the percentage by which it was missed. There has generally been improvement in the number of boards that met these goals in fiscal 2024. The second key observation is on the missed complaint investigation goals. Exhibit 7 shows the board's performance with the bold text indicating that a board missed the goal. 6 boards missed this goal in fiscal 2024, but this is an improvement from 12 boards in fiscal 2020. The Board of Dental Examiners and the Board of Professional Counselors and Therapists missed this goal and have not passed 50% timely completion in the past 5 fiscal years. The Board of Pharmacy showed improvement in timely completion from 42% in 2023 to 93% in 2024. The Board of Nursing had the lowest timely completion rate of 12% in fiscal 2024, but this reflects backlogged cases that were resolved through administrative closure. Exhibit 8 on page 15 shows the completed and outstanding investigations in the Board of Nursing and the percent that was completed in a timely manner. So as you can see, there's a big increase in investigations completed in fiscal 2024. And this includes cases prior to fiscal 2020 that were reviewed and administratively closed if they met certain criteria, such as cases that had stale evidence and in which there was no significant harm. There are currently about 800 outstanding investigations since fiscal 2020 that the board is working to administratively close. The third key observation provides an update on the Board of Nursing infrastructure operations transferred to MDH. Legislation transferred these functions to MDH for 2 years beginning in fiscal 2024 and is set to return to the Board of Nursing in fiscal 2026. There is a departmental bill that would extend MDH's oversight for an additional 5 years, and DLS has asked MDH to comment on why these functions would continue to be supported with general funds. There were 2 evaluations of the Board of Nursing that were conducted in 2023, one by a consulting firm and another by DLS's Office of Program Evaluation and Government Accountability. Exhibit 9 provides an update on the status of implementing the recommendations that were made by OPEGA, showing that 7 of the 16 recommendations have been resolved and the rest are in progress. One of the recommendations was to study the board's fee structure and estimated revenue by fee category. And so these are included on Exhibit 10 in page 19, the proposed fee structure and estimated revenue increase. And with that, I'll end my presentation, and I'm happy to take any questions.
Thank you so much for your thorough analysis. Does any member of the subcommittee have questions? Seeing none, thank you so much. We'll move right into our agency response. I've got Christine Farrelly, Lorraine Smith, and Rhonda Scott on our list. Are they here today? Anybody from the boards? Okay. Welcome back. Looking forward to hearing from you all. Sorry, our list is not entirely accurate, it seems. So you just go ahead and tell us who you are. Welcome to the table.
Sure. Thank you, Madam Chair.
Thank you.
Members of the committee. For the record, my name is Erin McMullen. I'm Chief of Staff at the Maryland Department of Health. I'm joined with Emily Brandenburg, the department's CFO, and then Rhonda Scott, the Executive Director of the Maryland Board of Nursing. There's also additional representatives from other boards in the audience, but our comments are largely going to focus on nursing today. As always, Ms. Martinez, thank you for your thoughtful analysis. As was mentioned, there's 20 health occupation boards at MDH, the majority of which are special funded based on licensure fees. With the exception of the Board of Nursing, the boards are largely statutorily independent from the department. Before we go into the DLS prompts, I did want to take a moment to highlight all the progress that has happened the past 2 years through the partnership with the Board of Nursing. 2 years ago when the secretary and I joined the department, there were a lot of different issues going on at the board that were brought to our attention and to your attention as well. Licenses, I'm gonna pause.
Until this passes, sorry. Give us a moment here. This is really important information. We don't want to miss out on it. Okay, go ahead.
All right. 2 years ago, licenses weren't being issued in a timely manner. We were getting reports that nurses were getting pulled off hospital floors because they couldn't get their credentials updated. And that was kind of in the most extreme cases. But you were all hearing similar issues from nurses, and a request was made to OPEGA to do this independent evaluation of the board. And emergency legislation was passed to move infrastructure and operations under MDH. As discussed in that analysis, that 2-year period is coming to an end, but the partnership between the board and the department is really stronger than ever. Really, it's so strong that the board voted to stay with the department for another 5 years. Under Rhonda's leadership, we have made so much progress and strides in a number of areas: technology, application processing, staffing, constituent services. We still have work to do, but the continued partnership really is necessary to make sure we resolve those other outstanding findings that were mentioned in the analysis, and help migrate the board to a new licensure system, which will really help leaps and bounds take the board to the next level. With that, I'm just going to jump into our responses. So concerning the DLS recommendation to reduce the fiscal 26 allowance by $6 million to correct a technical error, we do concur with DLS and would recommend the legislature take that cut to reduce the board's special fund appropriation. The next prompt relates to several fund balance reductions that are being recommended by DLS for additional health occupation boards. You have the written testimony for the boards related to each of those fund balance transfers in your materials. And then regarding the ongoing need for general funds and whether increased board fees are necessary, the existing legislative requirement regarding infrastructure support does end in the current fiscal year. The governor's allowance did not anticipate the sunset legislation would continue to fund the board's infrastructure using general funds, so there are no general funds appropriated in FY26 for this purpose. Should the sunset legislation pass as introduced, additional general fund support would be needed because the board is prohibited from using their special funds for that purpose. I do want to emphasize, though, whether or not additional general funds are made available, the fee increases that the board that are laid out in Ms. Martinez's analysis are definitely necessary. The board has a phased approach to raise fees through FY 2029 that Ms. Scott can definitely speak to if you're interested in hearing more about that. But even if that general fund support is extended, the board really does need to raise fees to be self-sustaining in the future. So thank you again for your time and attention. We're happy to take any questions you have.
Thank you so much for the testimony and for your thoughtful written response as well. It's very thorough. We appreciate that. Do any members of the subcommittee have questions? Delia Ruff, I see you reaching. All right, your turn.
Thank you, Madam Chair. I don't have a whole lot. I was just looking through the appendix on the last page and was kind of just trying to get an idea of the the budget and the way you guys have structured the cuts, and I think it's very reasonable and it makes a lot of sense how you guys increased salaries and wages, but made some cuts throughout to offset all of that. The only thing that stuck out was the 148% increase in motor vehicle expenditures. So I was just wondering how, what's that all about?
Hi, thank
Ms.
you.
Brandenburg, right?
Yes.
I figured that was a question for you.
Yes, my first question. That's associated with more gas and oil for travel and use of our state vehicles.
I'm guessing the federal government has nothing to do with that.
No, this is state funding.
No, never mind.
Or special funds.
Thank you.
Thank you, Delegate. Thank you, team. I have a quick question related to personnel recruitment, please. So if you turn to page 8 of the analysis, can you just please comment on the status of recruitment efforts for vacant positions?
Sorry, I just turned to page 8. Recruitment status for a specific board or all the boards in general?
All of them.
Sure. I know Ms. Scott can speak to the Board of Nursing. There are other members that can speak to their recruitment efforts, but do you maybe want to share a little bit about our partnership with hiring?
Sure. Thank you. Thank you, Madam Chair and members of the committee. So we've worked in partnership with the department in just improving our recruitment process and the timeliness of how we actually onboard, bring folks in and bring people in. And we've seen such a increase and improvement in being able to bring in qualified individuals. We've worked with them to look at job descriptions and ensure that they are consistent with the roles that and the duties that will be or necessary to conduct the work of the board. And so it's that along with the, the salary improvements and just working closely with OHR on getting recruitments out there and positions filled has been very lucrative and successful, and that's one of the reasons why we've been able to decrease our vacancy rate. We've also brought on a new director of operations just 3 weeks to the day, and so we're excited that he's also looking and prioritized filling the remaining vacancies that we have.
Okay, got it. I see just sort of related question on the table. It says that there are 3 regular positions being added and 9.88 contractual ones added as well. But given looks like the 3 additions are contractual conversions, is that right?
Yes.
Okay, and then the 9.88 additional people or positions rather on contractual, do any of them overlap with the existing vacant positions, or are they entirely different? Can you reprogram or repurpose any?
So the additional positions were awarded to the board back in September of '23 in an effort to assist with the complaint backlog. Okay. And we identified those as the non-nurse investigator positions, and that was part of one of the recommendations by the independent evaluator, that we bring on these individuals to assist with closing the backlog of complaints. At this point, we have 5 of those filled and 5 are vacant that we're actively recruiting for, and those 5 we actually are one of the ones that we reviewed the job description, looked at it, and made the job description, we reclassified them so that the actual qualifications will be met to suit the duties required of a non-nurse investigator. The 3 contractual conversions are just our attempt to, encourage staff about job security. As many of you know, contractual employment is not always the most efficient way of, encouraging staff that there is job security. And these are individuals who've been with the board in their roles for a while, and we thought it would be definitely important to keep them on. Sure. So that was one of the measures that we took.
Okay, and those that are being converted into regular positions are they don't address any of the existing vacancies that you are recruiting for?
No.
Okay, got it. Okay, thank you, that's very helpful. Delegate McCaskill for a question.
Thank you, Madam Chair. So please forgive me because I have so much MDH graphs and exhibits that I had to go, I lost track of my exhibit, but work with me here, please. So thank you. Can you comment on the reasoning for the proposed fund balance transfer for the Board of Nursing that would have left them in a negative balance after expenditures? And I wanted to refer to, I think, Exhibit 3. There we go. I'll refer back to my computer as well.
Yeah, I think we have it. Exhibit 3, this table here. I believe that for the fund balance transfers, nursing right now has a positive fund balance. When the sunset was passed in 2023, the board was operating in the red. Because of the general fund support that was provided, they are back in the green. I will say they do need to update their fees to get to a place where they have a fund balance, but the board, thanks to the general fund support from you all, has been able to build up a small positive balance.
Okay, congratulations. Thank you. Thank you, Madam Chair.
Thank you, Delegate. I see no further questions from members of the subcommittee. Thank you so much for being with us today. We do have one witness who is signed up to testify on panel 2, Michael Patty, on behalf of the Maryland Occupational Therapists Association. So once you get to the table, Michael, you can begin when you're ready. And 2 minutes, please.
Great. Thank you, Madam Chair. Michael Patty here today on behalf of the Maryland Occupational Therapy Association. We're just concerned with the proposed transfer of funds that DLS recommends on page 7 into page 8. Like last year, we viewed the transfer as detrimental to the interests of occupational therapists. who play a crucial role in the healthcare system. And we believe that the board should retain its current funds to ensure the continued support and development of the profession. I'm sure you all know how important occupational therapists are to the healthcare system and the roles and the challenges that they have in everyday life in their work capacity. By maintaining the fund balance, the board can ensure that resources are available to appropriately regulate the profession and advance it. Specifically, in 2021, the legislature adopted or passed a law that allowed occupational therapists to participate in the compact. That still has not been implemented yet, so we expect there to be some IT and other system upgrades needed to get that up and running in the state of Maryland. And then, lastly, there's always a concern when these fund transfers are approved that our licensees, may see a fee increase in the future, and certainly with the amount of money that's being recommended and taking from the board to the Behavioral Health Administration, that's certainly on the top of a lot of our members' minds. We recognize how complicated the budget is, this year, so we just ask the committee to keep that in mind as you consider this fund transfer. Thank you.
Thank you so much for your advocacy, for being here. Anyone have any questions? Great, thank you for joining us. Yep, that concludes our third and final budget hearing today. So our subcommittee is adjourned. Thank you.